Good afternoon. The title of my final work is Improving Parental Adherence to Vitamin D Administration for the Breastfed or Partially Breastfed Infant. My name is Tonya Lucas, and I'm a certified pediatric nurse practitioner in primary care. For the committee members, Dr. Maria Snell is also my chair, and Dr. Bijan Basaninejad is the collaborative physician, pediatrics at my clinic where I work. For the background to the project, the recommendation by the American Academy of Pediatrics is that all breastfed or partially breastfed infants receive 400 IUs of vitamin D daily to avoid bone malformations such as rickets, potential seizures because of the low calcium, and difficulty breathing because vitamin D plays that crucial role in lung development. I do work at a federally qualified health center, also known as the SQHC. The pediatrician and I sought to comply with this recommendation by starting them off initially with a 2-week sample of vitamin D at their first newborn visit. And that first newborn visit usually is about 3 to 5 days after birth. However, when these infants would return for their standard 2-week checkup, we found that many were no longer receiving the supplementation. So to increase parental adherence, I wanted to implement a quality measure to determine if there would be increased parental adherence to the daily administration of vitamin D to the breastfed or partially breastfed infant if parents receive an e-script that is sent to the pharmacy versus us giving them that initial in-office sample. The significance is this. In 2016, the National Institute for Health and Care Excellence concluded that there was no gold standard process for improving medicinal compliance. This affects advanced practice nursing when having to explain to patients in a short amount of time necessity versus optional use of the prescribed medication. Medicinal non-compliance leads to unnecessary disease progression, additional medical visits, and hospitalizations where an overwhelmed population of nurse practitioners exists. Nurse practitioners have a responsibility to improve medicinal adherence. In the review of literature, we use primary research publications via Maryville's library and Ovid synthesis. 15 articles were compiled under 3 themes for this project: incident of risk factors, parental adherence, and provider perspective. All of the research concluded that there is a need to follow the AAP's recommendations. Strengths of the literature were that most of the studies in the review appropriately randomized the participant group. The articles reviewed showed no evidence of forbidden research practices, meeting the legal requirements by receiving either through IRB approval or an ethics committee. Weaknesses of the literature were that many of the studies utilized social media platforms for survey responses, such as in a study by All et al., where inaccurate reporting of prescribing practices could have occurred. Case studies were completed with participants who were unaware of any type of vitamin D supplementation requirement. Gaps in literature: there was not sufficient data to know exactly how much vitamin D transfers to an infant via breast milk. Another limitation: many of the studies reviewed had limited context such as geographical location and socioeconomic status, which we will review with limitations further down the presentation. Theoretical framework: I chose to adopt quality improvement as a framework to guide my project. With the project subjects being newborns, a quality improvement project seemed most fitting to accomplish a small change using a small sample size. W. Edward Deming's plan to study ACT model helped to facilitate my process that was driven by quality improvement projects that aimed to create a process where newborn patients who are breastfeeding receive a prescription for vitamin D supplementation. For decades, organizations have been using the PDSA model due to the belief that statistical process can improve healthcare quality, specifically in reference to the belief that incorporating quality and process will reduce errors. The PSDA model allowed me to create a plan, do the plan, study and review data to determine clinical significance, and act by making recommendations for the process change based on the outcome of my project. For methods and design, this quality improvement initiative used a quantitative exploratory method to determine whether the intervention was effective and statistically significant. Subjects were chosen after inclusion and exclusion criteria was determined, with the chosen subjects' EMR access. Because the aim of the project was to increase parental adherence, nominal scales were used as codes to represent categories and characteristics for the quality improvement project. Nominal data was the simplest form of measure and could not be ordered or measured. This design allowed me to objectively quantify the relationship between an e-script and parental adherence to vitamin D supplementation within a small population. My sample for this project included the parents of breastfed infants and used one variable, adherence, to determine if there was a direct relationship between increased adherence when an e-script was provided. The sample consisted of 86% of parents who were compliant and 14% of parents who were not compliant. There was a total of 36 sample subjects. For data analysis, statistical analysis used was the one proportion z-test because the sample size was greater than 30 and the variance was unknown. The z-test is one which the z-statistic follows a normal distribution. It's best used for greater than 30 samples because as the number of samples gets larger, the samples are distributed normally. It was predetermined with at least 18, that I needed at least 18 patients' electronic medical records for data collection. We used a 0.5 as a predetermined value for comparison. One dependent variable, adherence, was used. There was no independent variable as we were only looking at one group, and this was per the discussion I had with statistical master Mark Paul. For the results section, you can see here the charts that give the data, and in the pie chart, for compliance, 86% was compliant, 14% was non-compliant after implementing the e-script versus the in-office sampling. Limitations for the project, methodical limitations. Numerical data prior to the intervention could have led to explanations as to why parents were not compliant and could have led to other interventions for the project. So even though I am using the one variable for adherence, I did not have data prior to say that there was a certain percentage who were non-compliant. And so maybe if I would have, again, I could have gauged some of the challenges and it could have led to a different intervention. Population-specific limitations, recall bias certainly could have existed because of the lack of consistency among providers with implementation. So if I was on vacation or a collaborative was on vacation and newborns were coming in, then they may not have received the education as discussed when the project was initiated, as well as the e-script. Another limitation was dosing of the supplementation variances among different brands. So this is what I learned from parents, that when they would come in, they would say, oh, the samples that we received from our baby showers, etc., they all say to do 1 drop. But the prescription that you sent to the pharmacy, it says to do 1 ml. And not realizing that there is the variance with brands on whether that 1 ml suffices with that 400 IUs or the 1 drop gives the 400 IU. So that is very confusing, and possibility of vitamin D toxicity is there. I mean, even now when we talk about measles, the outbreak and kids are getting vitamin A toxicity because parents are being told that vitamin A is what cures it. So again, the variances is important to point out because parents are unsure and they may not comply because of that uncertainty. Another limitation was the inability to measure with certainty the amount of formula a partially breastfed infant would receive. So when I talk about partially breastfed infants and why they are included in the project is because, say, a mother's milk has not come in for whatever reason, whether she had augmentation of her breast, stress, whether she's on a medication and can't produce, etc. Sometimes they will breastfeed their child, but they will also supplement with formula. Well, but if they're not getting the recommended 240 mils a day of the formula, they're not really getting the 400 IUs of vitamin D. And so it's almost impossible without them jotting down and charting for me the amount of formula and breastfed or breast milk together. And lastly, limitation, lack of education, provider and staff to parents. So did we all give the education that they needed? Did staff in those busy times provide the handouts for education? Did all providers who happened to be in office on a day give the education as discussed when we implemented the project? That is uncertain. In our discussion, only 1 in 5 breastfed newborns achieve the goal of receiving a daily recommendation of 400 IUs of vitamin D. Decreasing medication errors and improving communication via e-prescribing will provide for a more efficient and smoother workflow. To close the gap of those who do not receive the recommendation, causative factors for adherence needs further exploring. We need further research that needs to focus on identifying specific reasons that parents give for non-adherence and comparing adherence after suitable solutions are identified. Research shows that few clinical providers follow the AAP recommendation for vitamin D supplementation, and some do not even know what the recommendation is. So these are areas definitely that have room for growth and exploring on how to close these gaps. Implications for practice. Utilizing community health workers to follow up with parents routinely could improve adherence rates, specifically in the SQHC world. Community health workers are present and abundant based on grants. And so that is absolutely something that I believe we can implement and could improve adherence rates. Telehealth visits at the 1 week and 1 month visit could improve adherence rates as well, as long as the insurance will pay for it. Because what we have found is, like with Missouri Medicaid, sometimes if the patient has been seen within the last week, then we can't bill unless there is an issue. Government grant programs could provide cost relief and or transportation to the pharmacy to get supplementation. So if it is a transportation issue for these parents, then definitely Medicaid transport. Those are things that we can also have our community health workers set up for these parents. Providers have to remain consistent. And so when I started the practice, it was just me. And then my collaborative came along and agreed to do this project with me. And we agreed that it was the best practice based on the research that I provided. And so new providers coming in also should be educated on this policy, and it should be made policy that this is how we should practice. And of course, the education, we have to educate ourselves continuously. We have to educate new providers, new ancillary staff, etc., on why we implement the vitamin D supplementation. For conclusion, when I entered this advanced practice role 3 years ago, it was the expectation of my employer to come in and build a pediatric practice. For the first couple of years, I did not have the clinical support nor the collaborative who had the time or knowledge on building a pediatric practice. I was told that my collaborative physician was a family medical physician who saw children. And in fact, the last child that he saw was 7 years prior to me starting my role. So during the 2 years in the DNP program, I faced a lot of adversity, head-on challenges that my patients and their families were facing, such as anorexia, inability to get to specialty, which is 2.5 hours away from our clinic because of cost, transportation, inability to afford food, little resources for mental health. And so for me, I'm a fixer, and I could not fix those things right away. But because of the DNP curriculum, I still was able to improve situational assessment skills to address some of these real world problems that they were facing. Parents were skeptical because many were first time parents, and many were skeptical because I was a new provider. And so we recently had a pediatrician who had been practicing for 30 years lose his license from a domestic situation. And so I was getting a lot of clients who were already skeptical because they had been with him for 30 years. And then based on what happened, they were hesitant on getting with somebody new. But what helped with that skepticism was my ability to deliver information that was evidence-based. They trusted facts. They trusted me to find the answer based on studies, etc., which is a skill set learned really through the DNP program. Sure, we learn how to go on ovicensuses, and we learn how to research articles, since our bachelor days. But to actually take a problem that your patients are facing and go to research it and find evidence-based information, and to be able to somehow incorporate that in your day or in your plan for them, and them see you go through that work for them, it means a lot to them, and it meant a lot to me because every day I'm learning something new. When the program started, I did find it hard to pick a topic, and I was unsure if the topic chosen would be impactful enough. But the results clearly concluded that parents were more compliant when a script was given. And as far as picking a topic initially and having a hard time with that, it really was because of focusing more on what does the committee expect? What kind of topics does the committee expect? But as time has gone on and speaking with professors, etc., it was like, okay, we're just making a change. Just what can we do to make any type of change? What impact can we have on community? And so, because of the additional pieces to the project that I addressed with the limitations, I can now think of literally a dozen topics to cycle through a DNP project. I mean, it's specifically with socioeconomic factors as to why parents are non-compliant. That alone sets up a DNP project. For example, I could have, if transportation was an issue, then I could have done a project on transportation being provided versus not provided, and compliant versus not compliant. I could have done a project on educating parents at a monthly before your baby arrives meeting in the community, and then determine those who attended versus those who didn't attend their compliance with vitamin D. So it did open up a lot of avenues and areas to research. This proves that the art of nursing does not end with one successful find, and that it is the limitations we face that force us to continue researching and constantly seek evaluate, engage in new partnerships, and translate the evidence into practice. The DNP program allowed me to realize that although medicine seems to be about strength in numbers, nursing is about the strength in translating what we know through research, and that is what separates the doctoral prepared nurse. I hope you enjoyed my project. I worked hard on it. A lot of learning to be done from it, and I will continue to learn every day. I appreciate you, Maryville, so much. So much. Thank you.